أروى.
مرحبا بك يا برو.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. الصورة واضحة.
واضحة؟
أيوة الصوت واضح.
الصوت واضح.
أيوة.
الناس خشوا، في بعض الناس خشوا.
في بعض الناس خشوا والباقيين بيدخلوا.
طيب ورينا نبدأ 200.
أوكي. يا برو ممكن نبدأ. ناس 27 كلهم حسي بدأوا يدخلوا.
بدي يخشوا؟
تواصلت مع دينا، هندي دينا ذاتها دخلت. داخلين قاعد. أوكي.
طيب بسم الله الرحمن الرحيم and welcome to yet another lecture on tropical and infectious diseases. Up to now we have been cutting across all diseases. If you take this as a horizontal approach, we took disease by disease, analyzing its geography, maybe history, and the location, and the pathology and pathogenesis, and described the causative organisms and all what is related to it by diagnosis and treatment. So now we want to have another approach to infectious and tropical diseases. This approach is, since we covered quite a number of diseases, this approach is what we call vertical approach. Definitely a patient who comes to the clinic, he wouldn't say that they have trypanosomiasis or so. He may complain of somnolence, seizure, whatever. And somebody who comes with guinea worm may come with an erupting worm, which is from the skin. So you really need to have a vertical approach for a system. So that was done by the disease state, and now we're going to cut on the systems to see what are the possible causes of, for instance, a seizure or encephalitis. This approach, we can encompass quite a lot of diseases in one person, or we can reach a very rapid diagnosis because patients will present with their symptoms and signs of the system. And this you have to have a differential diagnosis. So if you have a patient with encephalitis, what are the causes? What in the history would you get from the patient that will help you reach a diagnosis? Okay, so this lecture is about tropical neurology. And I'm using this terminology in its loose sense, tropical neurology, meaning that I'm going to talk about neurological diseases in the tropics. Because if we limit ourselves to those diseases which causes neurology or neurological disease in the tropics, then they are going to be restricted to the tropics, exclusive to that area. There are not going to be many. So And talking about tropics, tropical areas or tropical countries, we cannot exclude other factors which will influence disease pathogenesis. And these have been said to be poverty, and you know, poverty is a key to all diseases. Education, low education, water supply deficiency, and sanitation again is inadequate in most places, and the population overgrowth in many African countries is showing a real toll on the economics of these countries. So overcrowding, overpopulated, poverty, lack of education, and the poverty not only at the individual levels but also at the government level. Governments are mostly, you know, cannot do what they wish to do by providing uh, essentials for life. So let us agree that we're going to deal with uh, tropical neurology in the sense that we are going to discuss some tropical diseases and how they are associated with tropical conditions. Okay, for a start, we can delineate diseases which can affect the neurological system exclusive to Africa or exclusive to the tropics. And this is can be restricted to one or two major diseases. One of them is trypanosomiasis. Trypanosomiasis causes neurological symptoms, going to death, and it is restricted to very certain areas in Africa. Even within Africa, it is restricted. So if I call it tropical neurology, this goes well. Okay. Second point is diseases which will produce neurological symptoms in cases of vector, presence of vector. For instance, arthropods can transmit a lot of viruses, which is restricted to that area where the arthropod is. Viruses like Zika virus is transmitted by Aedes aegypti, okay, and you cannot get Zika virus except when you get the vector. All right, true, it is rather small ways of transmitting Zika virus, but majorly by Aedes aegypti. So it's limited to this area. So this is one group. The second group is diseases which are prevalent all over the world, you know, but have particular importance and peculiar presentations and peculiar outcome in the tropics. Take, for instance, AIDS. AIDS is a worldwide disease, but in the tropics, being, you know, intersecting with poverty, intersecting with lack of education, intersecting with unavailable drugs, okay, this will result in an AIDS, HIV/AIDS, which is not totally different, but very different from the one we see in Europe, for instance, okay? And certain viruses, if you don't have good treatment of AIDS, certain viruses will come into play. For instance, cryptococcal meningitis, which is common in AIDS, is now not very commonly seen, or, you know, to a very large extent has been reduced in Western countries, while it's very prevalent here in Africa because AIDS is not being very well controlled. So there are some diseases which are have peculiarity because of the tropical conditions. So let's think that we would like to have a physician or a surgeon who works in the tropics, who is well equipped and armed by knowledge about the local conditions, be it exclusive to that area like trypanosomiasis, or be it affected by the factors which we call tropical conditions. Okay, diseases like rabies. We dealt with rabies last week. Rabies is a virus which is, transmitted from dogs, mainly dogs, but other vampire or bats can also transmit rabies. So in areas where there is caves and vampire, like in America, Latin America, and South America, when that is disease is which is bats related rabies is restricted to that area. However, rabies from dogs is worldwide, but is being controlled in the Western countries, and it remains a problem in tropical countries. So try to think of these diseases and their availability according to that condition. Viruses which can affect the central nervous system, like herpes simplex virus, can cause encephalopathy and can cause death, is very prevalent. Maybe that it is number one or two in Europe, which causes encephalitis. And it is important to recognize it, both in tropics and in the Western world. Causing encephalitis may be severe in the tropics, but it has to be recognized very early, because by and large, this is almost the only one cause of encephalitis which can be treated to cure. So these are the messages which I would like to give you in a nutshell. Okay, what are the neurological symptoms? What we are going to touch? Okay, uh, encephalitis, and some people call it encephalitis. I think it's encephala, and the L is stressed. Encephalitis. It is an inflammation of the parenchyma or parenchyma of the brain, while meningitis obviously is the inflammation of the meninges or the covering sheaths of brain and spinal cord. Okay. If you talk about myelitis, it is inflammation of the spinal cord. Okay. And the symptoms will go into uh, affecting the three major symptoms of the brain. One is consciousness. That is a function of the brain, a top-down function of the brain. We are aware, oriented in time and place. We can see and communicate. So consciousness is important, and we can degree of loss of consciousness can be from just being drowsy to severe coma. So that is number one. Number two is behavioral abnormality, and this is usually due to frontal lobe. You are not socially accepted. You do things which are not socially seen as appropriate, and this behavior will cause hallucinations, delusions, and the rest of it. And then cognitive function. This is the third function of the brain, which you have to bear in mind when you talk about diseases, is cognitive function or learning ability of the brain. So if you talk about, say, acute encephalitis, and this is obviously a major and emergency situation. The behavior is something which is subtle, okay? Which is subtle, but drowsiness and coma is very clear. So you have to be aware of picking up some what we call soft signs or soft symptoms of behavior and cognitive forgetfulness, coherence, drowsiness, all these delirium, halwasa. Okay, and then you will have psychiatric symptoms. Okay, hallucinations, for instance, can occur with organic inflammation of the brain, and can occur through schizophrenia, for for instance, or psychiatric illness. Okay, the acute encephalitis can be summarized causes into infection or non-infective or antibody mediated. And this acute encephalitis usually cross with HIV/AIDS. If somebody has HIV/AIDS with an infection, then the symptomatology will be different. Okay, again, malnutrition is another cofactor or confounding factor to severity. In HIV/AIDS, causes of the encephalitis is mainly HSV, which is herpes simplex virus 1, varicella, and rabies. Okay, in those who are immune competent are the herpes simplex and the varicella. But if you come to HIV/AIDS, we can see CMV, which is cytomegalovirus, and then another form of herpes simplex and toxoplasma gondii. These are in the HIV/AIDS. And then in the competent one is HSV, which is herpes simplex virus 1, varicella, which is herpes zoster and chickenpox virus, and then rabies. What about the post-infection? These are the infections which cause acute encephalitis. The post-infection, unfortunately, is measles, which measles is very common nowadays with the break of vaccine, and mycoplasma pneumoniae causing again the post-infection. So after the infection finishes, measles, you may get an encephalitis after a period. Okay, so let us talk about the commonest cause of encephalitis from the viral point of view. As we said, apart from certain parts of the world where Japanese encephalitis is a virus, another virus, this is very common in Southeast Asia, but in Europe and Africa, herpes simplex virus 1 is the commonest cause of encephalitis. And as I alluded to earlier, this is an important disease to recognize early because it is totally treatable to a level of cure. And the drug which is to be used is acyclovir. This is important. Acyclovir, ACYCLOVIR. I'm stressing this because you can save somebody's life if you know this is a case of herpes simplex and you give them this drug. They become cured to a level of death or total disability after the encephalitis. So it is that important. Okay, so this is a disease which is very, very calls for doctors' ability to diagnose early. And to the extent that if you suspect herpes simplex virus, you give a drug even before the investigation. Okay, what are the prodromal symptoms of herpes simplex virus? Okay, obviously headache, and headache is so non-localizing in neurological disease. Apart from certain types of headache, like the migraine, the early headache of increasing cardiac pressure, but headache is very common in herpes simplex virus. Headache is one. Important to have fever as well, okay, for several days. We will call it prodromal symptoms for several days. And then it starts behavioral changes and seizure, okay? After that, motor deficit will be apparent, and disturbance of loss of consciousness. So we hope that you will not allow the patient to get into the loss of consciousness. That is the level whereby we have had to intervene before then. Okay. So how can we diagnose herpes simplex virus? From the symptoms? And the most important investigation is lumbar puncture. Okay. Lumbar puncture is taking CSF is more important than MRI, because MRI, which is available now, CT is available, but the diagnosis rests on a lumbar puncture. And the lumbar puncture, you take fluid out, and then you send it for cells, proteins, glucose, microscopy, and most important, PCR, okay, polymerase chain reaction tests for HSV, okay, in the CSF. So if you have that facility, then at the end of the day, you will get certain diagnosis, and by then you know how to continue for treatment of the herpes simplex virus. So lumbar puncture is, as we said, is one of the important investigations which is to be done, and allow me to just go on to the basics of lumbar puncture, because this is going to be an investigation of choice for some diseases. Okay, lumbar puncture is puncturing between the vertebrae 3 and 4, getting into the space, and this is where the spinal cord has ended up, and we are going into the coding. Just taking the CSF, okay? It needs a technique here.
بروف الصوت ما واضح.
Vertebrae. Sorry?
كان واضح.
ما خشة واحد يبقى.
اوكي معلش.
هسي جوين ثاني؟
هاي لاحظ الصوت واضح والصورة واضحة.
أنا ما شفت الصورة. نعم. Okay, so the lumbar puncture, the position is very important, and then you have to identify the intervertebral area where you can push a needle. All of it is, a technique which is very simple, but has to have some precautions. You are going to get into the CSF, okay? You have to be severely aseptic, no bacteria, nothing to take in. So this is important, because you are going to in an area where if you give infection, you give problems like meningitis and maybe an abscess in the brain. So that is, cleaning is very important. 2, you have to be an expert. An expert is tried so many times, and now there is bodies in which we can try in, or there are simulators. It's important that you will get a CF. If you get traumatized, if you traumatize as you go in, you get blood. And presence of blood in CSF for diagnosis confuses the diagnosis completely. So if you are in the good techniques, you can puncture very quickly, you can get CSF out, and without infection and without blood. All right. The importance of the cells, the importance of the proteins, and the importance of the microscopy will give you a diagnosis of many diseases, which are either in the brain or in meningitis. The diagnosis of meningitis cannot be reached apart from doing a lumbar puncture. So although we have a lot of imaging techniques now, very advanced imaging techniques, still lumbar puncture is the ultimate and important one. This is why I would like you in this period to practice, if possible, lumbar puncture because you need it in emergency. What is the risk of lumbar puncture? The risk is obviously infection, and this is will be the doctor or the operator will be blamed. And then herniation, because if you take fluid out, then the brain sinks and will cause herniation. This occurs only or largely because of increased intracranial pressure. So if you want to do a lumbar puncture, you have to make sure that no increased intracranial pressure. And this we can do by fundal examination, looking for papilledema, or if you have an MRI, you can do it and it can be clear before the lumbar puncture. But in most cases, we don't need just examination of the fundus can tell you that there is no papilledema, and then this is a safe way. So the precaution after the puncturing the area, the patient lie, head down, okay, for fear of herniation. So apart from that, it is extremely useful investigation. So what do we look for when we puncture? Okay, you have to have a manometer. A manometer is a tube like that, which will be attached to the needle. And once you puncture and the fluid comes out of the needle, it goes in the manometer. And what we call the initial pressure has to be measured, and this is important. It is between 10 to 20 centimeters of height of CSF, and if it is higher, then there is high pressure inside, which means like encephalitis or myelitis or meningoencephalitis. So that's number one. Number two is we look for the color of the CSF and then measure the protein, measure the white cells, measure the glucose, and the microscopy. And cells could be white cells or mononuclear cells in lymphocytes or with mononuclear cells with another diseases like cryptococci or even tuberculosis lymphocytes, but sometimes you can get other types of mononuclear cells. So the color should be clear, the white cells should be very few, okay? Glucose is the normal, which is about 42 if you go with milligrams per cubic mil. It is 42 to 72. Okay, protein has to be lower than 0.5 grams per liter, and the cells has to be less than 5. So say it again, CSF color should be colorless or clear, okay? The pressure should be 10 to 20 centimeters. The glucose should be between 40 and 70, say, okay? Protein should be less than 0.5 of the gram per liter, okay? And microscopy should be clear, white cells very low, or 5. Okay, what are the three conditions which we need to look into skin? Take for instance, uh, pyogenic meningitis, okay? Pyogenic meningitis, we take TB, and then cryptococcal meningitis, which occurs in HIV/AIDS. Okay, in pyogenic meningitis, the pressure will be high, but the fluid will be very cloudy to purulent. Sometimes with meningococcal meningitis, if you push the needle in, it's so thick it cannot come out. Or if it comes out, it just pours pus. That is meningococcal meningitis, which is a severe meningitis and can end with bad sequelae. So the white cells will be more than 200, okay? More than 200 are mainly neutrophils. Okay, glucose is very low in meningococcal meningitis, reaching almost zero. Okay, and glucose is important because in other meningitis, then this is differentiating point. Okay, the protein is raised. The protein is raised. In a matter of fact, protein is raised in all types of meningitis, be it meningococcal, TB, or cryptogenic. So protein will be raised, but to a different levels. That is for sure. Okay, glucose will be very low in meningococcal meningitis, and then microscopy by gram stain, you can see the meningococci, okay, causing the meningitis. And it used to be very common in Sudan till we had a vaccine against meningococcal meningitis. Up to now, I think there are waves of epidemic of meningococcal meningitis in East Africa, and there is a surveillance office in Burkina Faso to assess the wave of meningococcal meningitis. So, what about TB? TB meningitis, and you remember one of the very first cases I gave you is tuberculous meningitis, if you remember. What is the CSF like in tuberculous meningitis? Well, number one, it could be clear, but it could be yellow, or it could be slightly cloudy. So that is the color. Pressure will be high, and white cells will be just over 10, mainly mononuclear cells, lymphocytes. Okay, glucose is low, but not as low as in meningococcal meningitis. Protein is raised, as we said, and then we do the Nielsen stain, which stains tubercle bacilli, okay, by the Nielsen stain, alcohol acid fast bacillus, and that will be, if you are lucky, you can get the Nielsen stain positive. Okay, but not usual. The amount of tubercle bacilli in CSF is not that great. So if you don't get it, that does not exclude the presence of tuberculous meningitis. Okay, what about viruses? Viruses, we said the protein is high. Okay, glucose is normal. That is the main difference between meningococcal meningitis and viral meningitis. Glucose is normal. Okay, cells again, just like tuberculosis, is not very high, around about 10, mainly mononuclear cells. Okay, and viruses, one of the most important tests is to send the CSF for PCR. Okay, for PCR, especially for viruses like herpes simplex virus. Okay, cryptococcal meningitis is still common in tropical areas due to HIV/AIDS, and it is more prevalent in patients who have HIV/AIDS uncontrolled, and it gives a very similar picture to meningitis generally, and has to be diagnosed because the treatment is totally different. Okay, cells as color will be clear or slightly cloudy. Cells just like tuberculosis or virus, about 10 mononuclear cells, and glucose is low, with protein is high, and then India ink positive for cryptococci. So this is in summary of lumbar puncture usefulness in diagnosis. So protein in all of them will be high, pressure will be high, and then the cloudiness is major in meningococcal meningitis, and then you have to take a CSF2 culture, all right, first gram stain culture for meningococci, and then the Nielsen stain for tuberculosis bacilli. And if you suspect in HIV/AIDS, you have to do India ink for cryptococci. So this is just an intervening part of lumbar puncture, and because it's an important investigation which you have to go through. Okay, other diseases, neurological diseases, which we see in the tropics, is what we call nodding syndrome. And nodding syndrome has been during when we were in the onchocerciasis control epoch. Nodding syndrome appeared suddenly in Uganda. And this is just people who have recurrent bouts of episodic head nodding like this, okay? But then they go into a sort of drowsiness and encephalopathy, and they have seizures. Okay, people were trying to link it because it appeared in the area of onchocerciasis, nodding syndrome, and people were not very sure if it is due to onchocerciasis with parasite in the brain, onchocerciasis with treatment, or is it due to the drugs? But anyway, it is a type of seizure which is, associated with onchocerciasis, and the outcome is not very good. It's usually in children between 3 to 18. Okay, so it is in certain areas, South Sudan and Uganda, nodding syndrome. Okay, seizure. The word seizure, the last time, I discussed febrile convulsions. We discussed in the last lecture when we talked about fever. But seizure, which is, an epileptic seizure, is generally an important indicator of cortical gray matter involvement. Cortical gray matter involvement. And it is non-localizing, meaning that it can occur with a lot of infections, it can occur with meningitis, and it can occur with CVA like hemorrhage, it can be idiopathic like in epilepsy, it can occur with febrile illnesses. So seizure is important, but the description of the fever is extremely important to the extent that we don't accept, because the patient may be in drowsiness or coma, he cannot describe what happened to him. All he can describe is he falls down and then he wake up very fatigued. Okay, so the description has to come from an observer, Okay, so the type of fever, be aware that you have to the type of seizure is different in different conditions. Okay, tonic, clonic, okay, like epilepsy, idiopathic, can occur with infection. You can have a localized, just one arm, localized tremor or localized fits, and that is, you may have a localization of the brain, irritation of certain area of the gray matter. Okay, what are the other conditions which we may see in the tropics? Neurocysticercosis. Neurocysticercosis, we already dealt with it under Taenia solium. This is the big worm, all right? And in certain areas where they eat pig meat, okay, or bacon, in areas like certain parts of Africa and certain parts of Latin America, South America, neurocysticercosis is the most important cause of epilepsy. Okay, just to remind you, it's a tapeworm of the pig, all right, and it goes in the muscles of the pig. Unfortunately, man is the definitive host, okay, as well as intermediate host. Intermediate host. And the problem comes from man being an intermediate host because the intermediate stage of the parasite is cysts. It's cysts, with colices, they are active, they grow, and if they go to the brain, they cause irritation and an effect of space occupying the. So it is a very important cause of epilepsy. There is now a protocol, the WHO protocol, of how to treat neurocystis or cosis, okay, by drugs like albendazole, ivermectin, and praziquantel. So that's another tropical, but it's not localized to the tropics, but it is localized because other areas like Europe have completely cleaned the pig from the Teniosolium infection. Okay, focal. You remember COVID-19? COVID-19 was a pandemic. It respected no boundaries, no political or geographical boundaries. It wiped out a lot of people, particularly in Africa. People will talk like COVID was less in Africa, and I'm not very sure. I have not been enlightened by data, but I think there is underreporting of COVID cases in Africa. And then they were playing it less and less. They are playing it less and less. And we have witnessed that in Sudan. They were talking about COVID as a joke. Okay? And this may be simulated also in other African countries. And we have even presidents denying the presence of COVID, and they thought this is a colonial attack on African countries. But COVID was a real. And here I'm bringing COVID as a cause of neurological diseases because all hospitalized patients with COVID had neurological deficit or abnormalities. And this is, they may have encephalopathy, encephalomyelitis, and stroke. So a virus like COVID, which have made a lot of difference in the spectrum of neurological disease in Africa. Okay, to diverge a little, what are the causes? Let us put the causes of seizures. Okay, obviously in non-tropical area, we think about idiopathic epilepsy or epilepsy general. But here we talk about bacterial meningitis, tuberculous meningitis, obviously cerebral malaria can give you seizures, TB of the brain, like tuberculoma, okay. Cryptococcosis is another cause of seizure, neurocysticercosis, as we have already said, toxoplasmosis, and hydatid cyst. You remember hydatid cyst has a picture very similar to cysticercosis because man is an intermediate host, and inside man you find the cysts. Okay. The only difference is that cysts of hydatid will have predilection to the liver. They are mainly in the liver and the lungs, and some of them go to the brain, while Teniosolium cysts go to the brain more often. But it is a cause of epilepsy or of seizures. Strongyloides, you remember, strongyloides is a nematode which goes all over the place, and if it rests in the brain, cause irritation of the gray matter, okay, and give you seizures. Tetanus is still common, and it has to be, differentiated from a lot of muscle spasm or muscle convulsions. Remember, we put it as differential diagnosis when we talked about rabies. Obviously, you have to talk about toxins. Alcohol is a toxin, which can cause fits and convulsions either on an overdose or when you withdraw. Okay, metabolic causes is again important, like hypoglycemia, hyperglycemia, ketoacidosis. These are give you again seizures. So the differential diagnosis of seizure is quite wide, but the tropical diseases takes quite a bit of the number of causes of uh, seizures. Okay. Uh, Trypanosomiasis, I come back to it, okay, because it's now in the 60s we nearly wiped out trypanosomiasis from Africa, but unfortunately it came back because the surveillance was slackened or weakened. Trypanosomiasis is a very restricted disease, very restricted disease. It is restricted where the vector is. And if you remember, the vector is glossina, or what we call tissy fly, or glossina. And trypanosoma is a protozoan infection. We have trypanosoma brucei, and that has two species. One is Trypanosoma rhodesiensis, rhodesia. Rhodesia used to be Zambian, and now Zambia used to be in the North Rhodesia, and now it is now changed into Zambia and Zimbabwe. Okay, Zimbabwe used to, before independence, used to be called South Rhodesia. So this is a parasite, a protozoan, named after Rhodesiensis. Okay, Rhodesiensis. Okay, and the other species, Gambiensis. Okay, why we are interested in this differentiation? Because Rhodesiensis is an acute illness. It's a very acute illness. You get fever, fatigability, just like you're getting a malaria, and then myalgia, and then suddenly headache, and you go into severe somnolence, sleepiness, dysarthria, then slight coma and death. Okay, that is the acute phase of rhodesiensis. The gambiensis is a chronic illness which starts with apathy, fatigability, psychosis, and then you get the typical picture of cerebral involvement of the brain, which affects the pyramidal, extrapyramidal, and the cerebellum. So that is a disease which is majorly a nervous system disease. This is why it's called sleeping sickness, because it causes drowsiness, lack of sleep. You always sleep, and then till you get into coma and causes death. So it is something which is localized, and unfortunately, there is no treatment up to now for that type of disease. Okay, toxins. Majorly toxins which causes neurological disease is botulinum toxin, and the bacteria is Clostridium botulinum. Okay, it causes, in short, it is called Botox, botulinum toxin, and it comes out of this bacteria, and it causes gastrointestinal tract abnormalities, like diarrhea, vomiting, and illness, general illness like toxicity. Okay, Here in the neurological field, it causes the synapse, okay? The synapse will get blocked, okay? Obviously, there is acetylcholine, and here you have a presynaptic release toxin, presynaptic release of acetylcholine, okay? So you will have sort of paralysis, and this may go on, to the parasympathetic nervous system as well. And here is the danger, because you can have respiratory arrest and you can have cardiac arrest from botulinum toxin. You remember we said that this is now used as a treatment to relax the muscles, because its job is relaxing the muscles, the botulinum toxins. For children with cerebral palsy, they have spasm of legs, you cannot walk. They inject them with botulinum toxin and relieve the spasm. Nowadays, cosmetologists use Botox, in the skin to relax the fissures and the folds of the skin and do cosmetic changes. Okay, you remember a disease which has a similar characteristic on the postsynaptic, the acetylcholine related, and it is called what? Myasthenia gravis. It's called myasthenia gravis. Myasthenia gravis is again the problem at that level of block of the acetylcholine. It has a characteristic. Early morning is okay. Midday and late day, the patient becomes almost paralyzed. Okay, drooping of the eyes and weakness. The danger of myasthenia gravis is if you have an involvement of the respiratory system, when you can have respiratory failure. Okay, the only difference between botulinum toxin and myasthenia gravis is that in botulinum toxin you can get autonomic nervous system affection. Autonomic nervous system affection. Okay, another disease which we need to talk about is Guillain-Barré syndrome. Guillain-Barré syndrome. I'm very much interested in the writing, because nowadays, if you write well, spell well, you can get the information. But if you feed Google the wrong spelling, then you get the wrong answer. This is why I would encourage you to get all these names correctly spelled. Okay, how do you spell Guillain-Barré syndrome? It's Guillain, Guillain. Barry, Barren, a dash on that. Guillain-Barré syndrome. It's acute, okay, can be primarily a viral disease or a post-infective disease. It usually starts from lower down the legs and goes up, okay, and it starts with sensory losses and areflexia. Basically, it's a lower motor neuron disease of the peripheral system, and it is often caused by a post-infection. The danger of Guillain-Barré syndrome is just like the myasthenia gravis is if it goes to the respiratory intercostal muscles, which is becomes very dangerous, and the patient has to be intubated and given support on the respiration. So these diseases, they're just like infections, and they go on, causing a lot of harm and affecting, something like the nervous system, which is vital. Okay, simple virus. I have always been intrigued by why a virus, for instance, like rabies virus, just restrict itself to the central nervous system. Nothing else. Hepatitis B virus. Why does it select the hepatocytes? Why does it select the hepatocytes? Herpes simplex virus. Why does it concentrate on the brain? Why doesn't it go somewhere else? So these are the important something which I would like you as critical mind to think why and how can we influence these diseases in a sense that we can control them. Okay, there is a post-rabies encephalomyelitis. You remember when we talked about rabies? Nowadays, we have a very good vaccine, very good vaccines, embryonic grown culture vaccine or tissue vaccine, which is given in 3 doses, day 1, 3, and 5. But sometimes you can get a demyelination state, which is now less and less with the new vaccines. But demyelination is in encephalomyelitis, a patient becomes encephalitic and loss of spinal cord effect. Okay, so it's unfortunate. I have seen 1 or 2 cases when the vaccine was used to be developed locally from brain tissue of infected dogs. Okay, what is Zika virus? Zika virus is now talked about mainly in obstetrics and gynecology, but it is a virus. Zika is a forest in Uganda. That is, the name came from a forest in Uganda, and nodding disease also came from Uganda. Trypanosomiasis is still there in Uganda, neighboring Sudan, and trypanosomiasis, unfortunately, it affects the cattle as well. Okay, so Zika virus is transmitted by a mosquito, Aedes aegypti. Okay, and Zika virus can be also transmitted by other modes of transmission, mainly the mosquito, but it can also be transmitted by sexual intercourse, by blood, and through the placenta. And this one, through the placenta, is the catastrophe, because if it goes to the baby, there is a very high likelihood that the baby will be born microcephalic. Okay, but in adults, if you contract Zika virus, you can also have an inflammation of the brain, encephalitis, or you can have inflammation of the spinal cord into giving you paralysis and the rest of it of myelopathy. Okay, but microencephalopathy or microcephaly is an important sequelae if it is transmitted through the placenta to a newborn and then there's almost an epidemic in certain parts of Latin America who have this microcephaly, very, very high price for an infection with a microcephalic baby. Okay, I think with that we have to close, but I just wonder if I summarize in 1 or 2 minutes. We are now into a phase of instead of getting horizontal on the diseases, now we're getting vertical on the systems to see what are the diseases, different diseases are now being caught by one in a system. Okay, that's number 1. Number 2 is tropical countries have peculiarity, and we have talked about the peculiarity of the tropical countries, which can influence the prevalence of diseases, even if it is not restricted to tropics, but it will have a different prevalence and a different emphasis. And we give the example of HIV/AIDS. Okay, poverty, sanitation, water supply, consanguinity, population increase, all these malnutrition type of food, all this will give you an environment, what we call a tropical environment for prevailing of these diseases. Okay. We talked about nervous system because it's an important and the sequel of affection of the nervous system is sometimes dramatic. Okay. Otherwise, we're going to talk about other systems. Hopefully, this will complete the picture of tropical disease. Our aim is to produce a doctor who can work in the tropics. Surgeon B, obstetrician B, physician or pediatrician. He has to know the complexity of the tropics to be able to pick up diseases which are peculiar to the area and to pick up diseases which are related to the environment of the tropics. One thing I would like to conclude that there are certain diseases which are prevalent in Western Europe are not common in the tropics, like myelinating disease or multiple sclerosis. It is not common in tropical countries. It is very common in the Western countries. Okay, and we should always remember that non-communicable diseases are now getting the priority, the highest level of affection. Okay, non-communicable, hypertension, renal disease, neoplasm or cancer, and cardiovascular disease like coronaries, diabetes. Okay, these are now also burdening the tropical countries, and it is getting more and more the upper hand on the infections. So tropical countries are plagued by these and by the non-communicable disease. With that, I would like to finish, and thank you very much indeed for being with us. Arwa will tell you that now the lectures are being delivered in a YouTube, which is available for anybody who want to approach these lectures and hope they're going to be useful for the youngsters. Thank you very much indeed. Bye.